Greetings again to the third day of FRCE's Virtual Behavioral Health Symposium. I'm Dr. Richard Gist, Deputy Director and Principal Assistant to the Fire Chief in Kansas City, Missouri. I want to introduce today's topics by making an observation about organizations like ours that function with particular missions in mind. A very good friend and colleague and mentor to me, himself a military physician, once told me that military medicine is to medicine as military music is to music. Now, that was a clever quip, but it was also a very apt observation because military medicine is involved in maintaining soldier readiness and fitness and capacity to carry out a mission. It's very mission focused. It also doesn't stop with just the battlefield or the operational setting. It's designed to help keep the soldier and all those who support that soldier, family, the co-workers, intact and focused all the way through their career and even beyond. As a consequence, it seemed logical when looking at how we would do our building of behavioral health professionals for the fire service to look to how the military builds its clinicians to serve its functions. My son is on his way to becoming a military physician and is a student at the Uniformed Services University of Health Sciences in Bethesda on the Walter Reed campus. They've been focused since the 70s on building medical practitioners and behavioral health practitioners also specifically to serve the U.S. military and support those missions. Indeed, USUS was intimately involved in putting together the original FSLI 13 approach and helping us learn to couch our thinking in the way that mission-focused provider support model that the military has made very, very much a part of everything they do. So we've invited today retired Navy Captain Kurt West. He spent most of his career as a Navy psychiatrist after serving as an operational officer in submarines, and has been involved for some number of years now in helping build the way that behavioral health is delivered to our U.S. military. There's a lot we can learn from how USUS and the military have approached this, and a lot that they, and especially the Center for the Study of Traumatic Stress at USUS, has taught us about supporting first responders in the work that you do. So without further wait, let me introduce Captain Kurt West, who will give you a good overview of how the military approaches its development of practitioners and its delivery of service.
Good afternoon, and thank you so much for inviting me to be a part of this symposium. My name is Kurt West, and I'm a former Navy psychiatrist and currently Associate Professor of Psychiatry at the Uniformed Services University. I'm here today to talk to you about how we create clinicians for the United States military. Importantly, I need to let you know that these ideas are my own and do not represent those of my institution or the Department of Defense. And also, I have no conflicts of interest related to this presentation. Allow me to start with my own story. I entered the Navy in July 1985 as a midshipman at the United States Naval Academy. I was 17 years old, straight out of high school, and I wanted to be an aerospace engineer, a pilot, maybe even an astronaut. I chose the Navy because that seemed to be the best way to do all of those things. Well, one thing led to another, and at the end of 4 years, I did earn my degree in aerospace engineering, but I had decided I would become a nuclear submarine officer instead. So I went on to complete nuclear power training and reported to my submarine as a division officer, the USS Norfolk. During that time, a friend of mine became ill and was hospitalized in a nearby where I was working. As I looked around at what was going on in the hospital, I made a decision that I would look into the possibility of going into medicine. Now, I knew I had 5 years to complete my commitment to the submarine force, so I just sort of tucked that thought away. After service on the submarine and completing my prerequisites for medical school, I went to the University of Michigan on the Armed Forces Health Professions Scholarship. I chose to pursue specialty training in psychiatry. Shortly after completing my residency, I was deployed to Operation Iraqi Freedom as Operational Stress Control and Readiness, or OSCAR, psychiatrist with Marine Regimental Combat Team 5. Not long after, I was reassigned to the Uniformed Services University Department of Psychiatry, where I began my academic career. And it was from there that I retired a few years ago and continued on as a civilian. So I tell this story because it makes several points relevant to today's topic. First, thanks to programs created by the Department of Defense, I was able to complete undergraduate and medical education completely debt-free. Second, like many in the military medicine today, I was fully immersed and understood the cultures of not one, but several military services. And finally, thanks to the opportunity offered me by the Navy, I went on and chose to serve a full career of 26 years. So what will I talk about today? In order to understand what it takes to prepare clinicians for the military, I'll first talk about the history of military medical programs, and then specifically about how we train our students at the Uniformed Services University. I'll then go over some of the history of military psychiatry and mental health and principles that are common to military mental health care, particularly as it pertains to sustaining service members in extreme environments. And that will lead me to a discussion of the core components of training professionals and establishing their professional identity as military mental health clinicians. And it's through that discussion that I hope to encourage all of you to think about parallels within your own organizations or directions you might consider in developing a workforce to take care of your responders. So first, a brief overview of the history of military medicine, particularly military medical training and preparation of physicians for the military. Prior to World War I, military medicine was largely isolated from the rest of medicine. There were not a lot of doctors, and when more were needed in time of war, they were drawn from the pool of physicians around the country and then returned to civilian life when the war ended. Following World War I, the Army established the first internships at Army hospitals, and graduates of those training programs went on to serve as medical officers assigned to Army units. World War II placed enormous demand on the US medical system to supply professionals. And this was interestingly occurring at a time when the medical workforce was becoming increasingly specialized and requiring longer periods of advanced training. So in 1944, a civilian advisory board of medical specialties suggested to the military that it create its own residency training programs. The concerns raised were that during the war, the demand for military physicians may place a significant drain on civilian training programs. But then after the war, as those physicians who had left training came back, in addition to newly trained physicians, they would exceed the number of available training spots. So the recommendations of this report actually led in 1946 to the formation of the first medical residency training programs in the military. During the Korean and Vietnam Wars, as the draft was the norm, the ranks of military physicians were filled by a so-called doctor draft, or the Berry Plan. This is named after Assistant Secretary of Defense, Dr. Frank Berry, and he responded to concerns that the selective service system would draft prospective physicians out of medical schools and training programs, thereby leading to a subsequent shortage of physicians when they were most needed. So his program created a plan through which graduating physicians or medical students could voluntarily agree to serve in the military following their internship or residency training. In return, they would be exempted from the regular draft. This was an exceptionally successful program, and it brought in over 42,000 physicians over 25 years. However, President Nixon called for an end to the draft in 1970, and this created an imminent end to the value of the Berry Plan and recognized the need for a reliable supply of physicians. So Congressman F. Edward Hebert, for whom our medical school is named, of Louisiana, championed what he called a West Point for doctors. The Uniformed Services University of the Health Sciences would provide unparalleled education in health sciences, and the nation would gain a strong cadre of career medical officers. Secretary of Defense Melvin Laird realized a federally run medical school could be an important and powerful adjunct to military scholarship programs. In 1972, Congress passed the Uniformed Services Health Revitalization Act and created the two programs still in place today to train medical personnel for the armed forces. The Uniformed Services University, located in Bethesda, Maryland, is truly America's medical school. Students at the medical school pay no tuition and commission as officers into one of 4 uniformed services prior to beginning their first classes. In return, graduates complete an active duty service commitment of 7 years for the Army, Navy, and Air Force, and 10 years for the Public Health Service. In addition to the School of Medicine, USU is also home to a graduate school of nurses. There, active duty nurses can complete advanced degree programs that enable them to license as advanced practice nurses, including psychiatric mental health nurse practitioners. USU is also home to a College of Allied Health Sciences in San Antonio, Texas. In this school, enlisted medical technicians can train in a wide range of health services, with many programs conferring associate's or higher degrees. And finally, USU offers graduate programs in many sciences, but most significantly, a PhD program in clinical psychology, which trains active duty clinical psychologists. There are a couple of other programs in addition to USU that train future physicians and medical professionals. One of these is the Armed Forces Health Professions Scholarship Program, also established in 1972. This program provides full tuition and fees for medical, dental, clinical psychology, and several other health professions. All students receive a monthly stipend to cover most living allowances, and many are also eligible for signing bonuses when they enter school. An additional accession program is the Financial Assistance Program, or FAP. In this program, physicians in specialty training are given annual grants and a monthly stipend in addition to their standard resident salary provided by the hospitals where they train. Graduates of both programs receive these benefits in exchange for service commitment upon completion of their medical training. As I said, since the end of World War II, the armed services have offered an extensive program of graduate medical education. Physicians train in accredited medical specialty programs at 21 military treatment facilities around the country. Training is available in everything from family medicine to neurosurgery, from psychiatry to aerospace medicine. With approximately 3,000 physicians in graduate medical education each year, this represents fully 1/3 of all active duty physicians. The number of specialty training positions is centrally managed according to the needs of the services by the Joint Service Graduate Medical Education Selection Board. Looking at this map, you can get an idea of the breadth of training opportunities that are available to military physicians. So now, if you'll indulge me, I'd like to talk about the process at the Uniformed Services University through which we create our military physicians. I will talk about our curriculum. Like all medical schools, our students begin their education with a core curriculum of basic biomedical sciences. Over 18 months, our students study biochemistry, anatomy and physiology, pharmacology, neuroscience, and pathophysiology organized by the various body systems. They also learn epidemiology and biostatistics, as well as the system science behind the delivery of healthcare. This period of classroom instruction also includes introduction to basic clinical skills such as medical interviewing and physical examination. After 18 months of preclinical education, we send our students out across the country for the clinical portion of their education. This includes core clerkships in medicine, surgery, psychiatry, obstetrics, pediatrics, and family medicine. Students have the opportunity to train in military treatment facilities across the country. After completing these core rotations, the students then have their opportunity to create advanced clinical rotations tailored to their interests. This 2 years of clinical education is a time when students not only learn clinical medicine, but they learn it in the setting and with the populations they will ultimately serve. But what really makes USU unique is our military-specific curriculum. More than 60% of our students enter USU with no military experience. Others come with varying levels of military experience, from a few years of enlisted service to actually commanding units in the field. It's important that we graduate all of our physicians with the basic military knowledge to not only provide culturally competent care, but to thrive and lead in their respective services. We accomplish this through a collection of field practicum exercises, leadership development, and summer operational experiences. In just their 3rd month of medical school, our students get their first military field experience. During Military Field Practicum 101, they learn basic field medical skills, tactical skills, and small arms training. Not only that, we train them to serve as casualty role players for the large-scale field exercise we put on for our senior medical students. More about that in a moment. As they progress through school, they complete a series of additional field practicum exercises. Each of these challenges their leadership skills as they tackle increasingly complex problems in larger and larger teams. In addition to the field practicums, students have the opportunity to spend time with medical units out in the operating services or in service schools to learn additional military skills. But absolutely, the capstone of our military-specific curriculum is a field exercise, a 4-day battlefield medical simulation called Operation Bushmaster. In this exercise, students complete a simulated deployment in support of military operations. They must manage a constant flow of battle casualties and routine medical problems during long days out in the field. In addition to demonstrating individual competence in stabilizing casualties, students are also evaluated on their leadership and their communication and their ability to recognize and manage combat and operational stress. I offer this information not to encourage you all to send all of your children to medical school at USU, but rather it's an excellent example of the components of preparing medical professionals to serve in the military. In order to create these clinicians as part of our military, absolutely, we have to ensure that they are clinically competent, And this could be accomplished at any medical school across the country, although one might argue that there are mental health skills that are very unique to military clinicians. But a capable military clinician must also achieve a degree of cultural competence and must understand the principles of effective support of military operations. And it's the addition of these attributes that make up the secret sauce needed to bridge the two worlds of medicine and the military. Now, I mentioned that there are some mental health skills that are unique to military clinicians. To better understand this, let me turn our attention to a very brief history of psychiatry and behavioral health in the military. So, military mental health has at its core understanding and responding to human reactions in extreme environments. For as long as there has been combat stress and adverse reactions to it. At the time of the Civil War, reactions to psychological trauma were starting to be recognized and codified and were commonly referred to by names such as soldier's heart or sick sergeant's syndrome. During the First World War, the term shell shock came to describe the reaction as the industrial scale horrors of modern warfare triggered a broad range of neuropsychiatric symptoms in soldiers. Now, in the early years, the standard treatment was to evacuate such soldiers, but it was recognized fairly quickly that evacuation also led to severe and persisting impairment back home. And so care was shifted closer to the front lines. And this was the development of the principles of combat casualty care of proximity, immediacy, expectancy, and simplicity, or PIES. This approach led to a significant employment of psychiatrists to treat these casualties much closer to the battlefield than had been past practice. World War II led to a significant effort made to screen out recruits for psychiatric illness and exclude them from military service. The intent was to prevent psychiatric casualties on the battlefield. Unfortunately, at the time, psychiatric diagnosis was not well or consistently defined. And when the Army reviewed the data in 1944, it discovered that nearly 2 million men, almost 15%, were excluded from military service, and there was no reduction in psychiatric casualties. And not only that, when they examined the service records of a collection of soldiers who were inducted but should have been screened out, almost 80% of them went on to serve honorably with no problems. So the senior psychiatric consultant to the Army at the time, Dr. William Meninger, recorded many lessons learned from the war. Chief among them was the need for a more systematic psychiatric diagnostic framework. And this ultimately led to the creation of the Diagnostic and Statistical Manual of Mental Disorders, or DSM, which is in its fifth revision currently and still in use today. Following World War II, there were a significant number of returning service members who experienced psychiatric difficulty upon their return. At the time, mental illness was largely out of sight for most Americans, and many in the greatest generation likely suffered in silence. It was not until the Vietnam War that psychiatry and society finally recognized the constellation of symptoms of re-experiencing emotional numbing and avoidance and hyperarousal in some soldiers returning from combat. In 1980, the first diagnosis of post-traumatic stress disorder was codified in the Diagnostic and Statistical Manual. So out of the experiences of the 20th century, military mental health has developed models of both understanding and intervening in extreme responses to stress. These represent core competencies for military mental health clinicians. The first of these is the stress continuum model. This model is a way of conceptualizing reactions to stress of varying degrees, from being late to work to seeing a teammate killed in action. It encompasses a range of reactions from normal to pathologic, and in so doing, suggests the intensity of intervention. More importantly, it has created a common language between medical personnel and warfighters to maintain a mutual understanding of stress response. Understanding the stress continuum is one of many core elements of clinical competency for military mental health clinicians. Beyond clinical competence is cultural competence. The military is a unique culture, and the various branches have their own unique subcultures. Military culture has a language, a code of manners, norms of behavior, belief systems, dress, and rituals. Military training indoctrinates members into the expected norms and mechanisms of maintaining those norms, and in the process replaces many of the cultural norms that recruits bring with them into the military. Enculturation does not only include service members, it also includes military families. Frequent moves and welcoming military communities at each base create their own social norms for military spouses and families. As a result of the close bonds formed in operating units and frequent moves, military culture can often create rather closed groups. And these groups can be resistant to accepting intervention from outside mental health providers. Learning this culture is an essential part of development as a military mental health provider. So clinicians develop their understanding of military culture in many ways. Many come from the ranks of those they train to serve. Others gain knowledge through basic military training on entry. Those who train at military treatment facilities where they wear the uniform and work daily with others who do. Military mental health clinicians gain the greatest degree of cultural competence through assignment as embedded behavioral health providers, assigned to the staff of operating brigades and regiments and ships and wings. Military clinicians split their time between direct clinical care and preventive care or outreach. They accompany their ships to sea and their units to the field to train and to operate. And in so doing, they develop a deep understanding of the units they serve and help those units to become more psychologically minded. Following embedded assignments, military clinicians are able to bring this knowledge and experience back into the military treatment facilities where they train the next generation of clinicians. An overarching principle of preparing military clinicians is recognizing the importance of operational support. The military health system exists to prepare and sustain a medically ready fighting force. For mental health clinicians, this means understanding the relationship between the care they provide and the ability of their patients to execute the missions assigned to them. Understanding operational support starts in training, as even early on, military clinicians must offer a determination of a patient's duty status in conjunction with every encounter. As they move out through embedded assignments, they develop understanding of the importance of preventive interventions, working with leadership teams to create environments in which service members can thrive. Finally, they gain an appreciation of the importance of being known to the units they serve. Being a known entity creates an environment in which they can be sought out for help. One of my own experiences with this took place when I was embedded with the Marines. At the beginning of my first deployment, I was called to examine an officer who had suffered multiple concussions from blast exposures. We took good care of him, and we kept him with his unit, and he went home with them. But months later, back in the States, he happened to run into me on one of my walkabouts with the unit. He asked to speak with me privately and told me about the continued difficulties he was having and how he did not want it to affect his work. We were able to get him needed treatment. But I think had it not been for my presence as a known entity, that might not have happened. Understanding effective operational support entails understanding both tiers and phases of support. It's useful to conceptualize psychological support as being implemented in different tiers. That means as the level of acuity or complexity increases, the level of support must adjust. And at the lowest level and most commonly employed are self-help measures. Self-help contains an enormous range of interventions. And some of these you might not think of at face value as self-help. Most people would recognize psychoeducation and relaxation technique as self-help interventions. But other interventions for self-help could include physical fitness, nutrition. There are many aspects of self-care which, if attended to, may facilitate resolution of stress reactions. Beyond self-help, there's peer support. This includes formal peer support programs in which designated individuals get additional training as peer support specialists. But it also includes the creation of an organizational climate in which healthy communication between group members is the norm. This can be developed through organizational practices such as team huddles or after-action reviews in which team members share experiences. What went right? What didn't? Through this process, sometimes emotional reactions are processed, but more commonly, distorted perceptions of shame and responsibility may be corrected in the background within individuals. Team members can more readily recognize distressed teammates and offer support. So it's also important to recognize self-help and peer support as really the foundation of any effective wellness program. Beyond self-help and peer support are what I like to call leadership and organizational interventions. Effective leadership, particularly risk and crisis communication skills, can be an intervention for distressed individuals. Creating an organizational climate in which help seeking is not perceived as a weakness or a violation of trust promotes resilience. Leadership intervention recognizes sacrifices team members make in service of the mission. And after losses, leadership provides a framework for processing collective grief. In addition to leadership, organizational practices, things like management of work schedules, provision of protective equipment, and clear definition of mission are also supportive interventions. And finally, at the top of the pyramid, we have screening and referral for treatment or clinical care. Effective operational support also recognizes distinct phases of needed support. All military units go through cycles of preparation, deployment, and recovery and reintegration. Whether ship or squadron deployments, training missions, or combat deployments, this cycle presents predictable stressors and points of intervention. Preparation for deployment typically occurs over months, but in emergent operations might take place over just a few days. Anticipatory anxiety, fear of unknown dangers downrange, questions about one's own ability or your ability to rely on fellow team members, and anxiety for care of the family left behind are common concerns. Fundamental interventions at this stage are education and planning. By education, we mean training. Realistic training that ideally simulates the situations that service members will encounter. And through doing this, this enables them to develop their confidence in their ability to handle those stressful situations. In addition to training, there can also be education about hazards, ways to protect themselves, or how to use types of protective equipment. During deployment, monitoring and brief interventions by leadership and mental health support are the primary interventions. Following deployment, it's important not to underestimate the stress of returning back to life as usual. Spending an extended period of time in a tight community on a high intensity mission is not always easy to come down from. Some individuals may have sustained lasting stress injuries or developed mental illness as a result of their experiences. For families, new routines have been established in the service member's absence, and it may take time to reintegrate into the family. These elements of cultural competence and recognition of the importance of operational support are the key to bridging the two worlds of those who may need support and those who are trained to provide it. And perhaps the best way to demonstrate this is through two examples. And what I'm going to show you is these are examples of how, by knowing and being part of a military culture, I was able to tailor my message to specific audiences. So the first example I have is a briefing I used to give to senior enlisted leaders when I was part of 1st Marine Division. You know, how do you get across to a group of battle-hardened staff sergeants, infantry Marines, the idea of combat stress reactions as expectable and recoverable? Well, knowing a little bit about their culture and spending time with them certainly helps. So I used an analogy. I told them to imagine their Marines on an extended march or run, and they take them out to a spot that's maybe a little too steep, a little too rocky, maybe they push them a little too fast. And they think about how many Marines are going to get hurt, at least a few. And they all recognize this is easy for them to recognize. But all those Marines are going to keep pushing because they're Marines and that's just what Marines do. Well, combat stress reactions and injuries are very much the same thing. You push Marines to an emotional breaking point and some of them will be hurt. The important thing to remember is that in both cases, with the right care, a sprained ankle and a combat stress injury can both eventually recover. So now let's bridge over to the other world, right? So moving back to USU, I was responsible for teaching medical students about combat stress reactions and injuries. That task was less about translating the neuroscience, but more about helping them understand the real world application of it. The medical students had a great understanding of the brain regions involved in stress and threat response. What they needed was a framework in which that system worked. So, but as you can see, both presentations end up in the same place. It just took a different bridge to get there. Finally, in the spirit of bridging two worlds and to bring this full circle, I want to finish with one more story. In March 2020, New York City experienced a massive COVID-19 outbreak. Many of you listening to this presentation have firsthand experience with this event. As large numbers of seriously ill people began to overwhelm the hospital systems across the city, the military was called in to help. Several field hospitals were mobilized, including the hospital ship USS Comfort. And although these medical units started out downtown at the Javits Convention Center, it quickly became apparent that their personnel would be better utilized in support of area hospitals. So importantly, as medical workers started spreading out to the different hospitals in the city, their embedded behavioral health support came out with them. And taking notice, the wellness officers of New York City Health and Hospitals and representatives from the Greater New York Hospital Association asked the mental health teams if they could help them develop better programs to sustain their healthcare workers in this unprecedented surge. Over several weeks, the Healing, Education, and Resilience for New York's Frontline Workers, or HERO New York, was born. This collaboration equipped a cadre of healthcare workers across the city with tools and techniques to help their peers using principles of military combat and operational stress control. This collaboration continues to this day and is an example of the valuable experience that military mental health can offer our colleagues outside the military. And by bridging those two worlds, it represents a great exclamation point on why we prepare our military providers. Thank you.